Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. Hope you're having a good June or had a good June, because now we are at Top 10 Tuesday, which is the last Tuesday of the month, hashtag Terry Tuesday, and I do a top 10. And recently I did a podcast on Are You a Coder or a Biller? And so today I actually wanted to kind of keep that theme going. I did one of these a while ago about best practices, the top 10 mistakes, but I want to talk about what they are and how to avoid mistakes in coding and billing. So let's kind of take a look at that and just see, what we can do to maybe help mitigate that problem. But first, the Codecast podcast is also brought to you today by Decision Health. Join Decision Health this November for advanced specialty coding virtual summits. Dive into orthopedics, pain management, anesthesia specialties, and get the latest guidance for accurate coding, billing, and compliance. Visit codingbooks.com/events to register. Save $50 with coupon code ASC2024. Okay, so let's talk about this here a little bit. So obviously medical facilities do a lot to really tackle patients' physical health. But what about financial health? That is an issue because problems with medical billing and coding can cause a lot of headaches for patients, especially when they think that they can't get any help to resolve some of the billing issues, or if they get an EOB or, something that explains that something didn't get paid, what is going to happen? And a lot of times it's not just in the hospital setting, but it's also in the provider setting. I know that about a year ago, I had a huge bill from an ER visit, and it's still not resolved. But it says on my EOB that it's not my responsibility. The hospital failed to get any kind of authorization. They had 3 days to do it. They never did it. And they kept calling me for my insurance card. I gave it to them 6 times. And so who knows what's going to happen with that. But luckily I have something in writing that says it's not my responsibility, but you know how that goes. So when we talk about some of these billing or coding mistakes, I know for those of you that are coders, you're thinking, well, that's the billing office. And some of you that are billers or collectors, you're thinking, well, the coders did it wrong. Well, let's try and really work together. Because there is I saw it in the Journal of American Medical Association, and I've also seen this on AHIMA's website, where there's a new percentage value that from a study, and it said, and this was crazy to me, that most clinics account for 15 to 25% of inaccurately submitted claims each month, and that means they need to be reworked. So think about that from an annual loss of revenue. That could be tens of thousands of dollars in just the healthcare field. So it could be incorrectly entered or missing information, and why medical claims basically get tagged for denials or, just for more information. And we just have to make sure that because of this, we're not discouraging patients from visiting your clinic or putting it off any kind of medically necessary treatments. One of the number one reasons that, patients don't come back to their physician's practice, according to surveys done by payers, is the fact they still have a bill there and they're embarrassed or think they're going to get charged for something that they don't have the money for. And so we just want to really look at possibly making things a little more error-free, compliant, and procedurally a little bit better workflows when it comes to making good choices as a coder and a biller. So let's take a look and see what we can do to kind of make this better for not only yourselves, but also your patients. So you can guess probably main reasons why medical billing claims get rejected. And there's just some things sometimes that are lazy mistakes. Maybe there's slips of the fingers or inattentiveness, transposed numbers, but let's really take a look at some of this. And, it's interesting because I think some people kind of miss what happens as the patient comes in the front door. And that's failure to verify insurance. That's number one. And I'm going to give you the top 10 since this is Top 10 Tuesday. Failure to verify insurance. Okay, this can cost you an arm and a leg. This is one of the core issues for most claim denials. Usually this problem comes from routines that aren't fixed from a compliance standpoint. So the patient, pays a visit to your clinic frequently. The staff just assumes that their insurance hasn't changed. They don't check on the terms. They just, say hi to the patient, take their $10 to $50 copay, but they don't ask the right questions. Is your insurance current? Just to trigger, oh, wait, I have a new insurance card. So those kinds of things, it's crucial to be attentive to both new and returning patients. Otherwise, you're just going to be spinning your wheels. Incomplete claim information. Oh, let me just go back to the failure to verify insurance. And again, a lot of this I can also take from personal experience. So I switched insurances recently and went to my primary care doctor just for a checkup, but also stopped by the downstairs lab because I get lab tests every 6 months. Borderline diabetic, so I make sure that my labs are done. And gave my insurance card to the front girl. She goes, oh, we don't take this here. You have to go down the hall, turn right, blah, blah, blah. I'm like, okay. So we went down there, gave it to the person, got their name and everything. Of course, we got our lab work done. And did she enter this into the computer? No. So it went out on my old insurance and I get a bill for $84. Then I call them. Of course, it goes to voicemail. Sent them. Then I was like, okay, this is my insurance. Here it is. Put it in my patient portal. There wasn't anything I could have done more to make sure that they got it. And they were pulling my billing information from my portal. What did I get in the mail? I got a bill saying that this was denied. So now I owe $84. So now I've got to use a stamp. I'm not trying to be petty, but let's face it, I shouldn't have to. And I had to take a copy. Luckily, I have a copy machine in my house of the front and back of my new insurance card, attach it to the bill. And, this is 2 months later. Think of all this work and all this expense to get just the $84 and sent it into the lab. So I'm hoping now that this is going to be billed correctly. But the number one thing is verify the insurance and find a way to have a go-between and somebody who's held accountable. When somebody does give you your updated insurance, especially for returning patients, that somebody has to put it in and they verify that information. You can tell I'm a little hot about that. That just bugs me. I don't like it when people fall down on the job, or I don't know if it's laziness or just they don't care or what, but that really bothers me. Incomplete claim information, that's number 2. So any missing data can be the reason for claim rejection. It also can be the reason that Medicare could opt you out. I just saw something recent on that. So even some basic fields on the billing form, the claim form, such as gender, date of birth, date of accident, date of the medical emergency, date of admission, the onset date, those sometimes are left blank, and the payers need that. So double check all the claims for missing or incorrectly entered fields and attach all the required documentation to avoid medical billing errors if documentation is necessary. If you're working with electronic claims, make sure your software flags users to input all the required information before allowing them to hit submit on that claim as well, because this is a problem that really can be avoided. So when we look at number 3, now we're looking at further documentation. So there's a lot of requests to support medical necessity, and sometimes you might even need to have that before filing the claim, but typically it's upon denial or upon review. And this can include medical histories, possibly physician records, discharge summaries, etc. So lack of documentation equals no service provided according to the Social Security Act. And they instruct CMS and Medicare not to cover services that are not necessary for the diagnosis or treatment of an illness. And so when you keep those things in mind, you'll know what you need to send when they request additional information. But the first thing when you have a request for additional documentation or additional information, make sure that you look at the deadline, because that's where I see a lot of problems where not meeting those deadlines can be the issue. Then number 4, lack of specifics. So insurance companies often reject claims that weren't coded to the highest level of specificity. I actually have a lot of surgery clients that find that some of the basic or base surgery codes actually pay a little more than some of the more complex codes or a combination of codes. So they're saying, can I just bill this code instead of what I actually did? And the answer is no. Each diagnosis must meet the maximum number of digits coded, so that's with ICD-10. But you also have to report exactly what you did. Also, make sure you're training your staff. When your staff is not trained explicitly for these specifics, they might make this this coding mistake from time to time without even realizing it. And one thing that I really feel bad for a lot of coders is that they're thrown into a job where they're expected to have the same degree of clinical that the physician does, and that's not fair. So you really have to make sure that you have your coders and billers equally trained. So what was that? Number 4. So number 5, missed filing deadlines. Oh boy, this has been, I don't know, bane of my existence. When I see a lot of, when I get asked by attorneys to come in and take a look at a practice, even though the claim may have been filed correctly, sometimes it's not submitted within the timely filing window, and you will risk that rejection. So Medicare providers should keep that in mind, that the Affordable Care Act reduced the period for claim submission from 27 to 12 months. Yeah, the AC isn't your friend. I mean, it definitely changed that. And, the claim needs to be sent before that end date, or it can be denied. And a lot of the commercial plans and managed care payers, they actually have some 3 months, some 6 months. And so you don't have that over 2 years anymore. You have to make sure you've hit your claims filing deadlines. Next one is miscoding and typing errors. So as mentioned before, each diagnosis must be coded to the highest level of specificity, is what the rules say. But that's sometimes more, easier said than done. I see sometimes incorrect dates. I've seen mistaken patient's name or using nickname. I've seen errors where, this one is really bad. This is where whoever inputted, or however the information was given to you for updates for ICD-10 codes, they inputted it incorrectly. And now your staff goes in and pulls up the code, and what they pulled up, they're pulling up something that's coming from your file maintenance or your hard drive, and they think it's the right code, and it turns out it isn't the right code, or it was a retired code, or it's been an updated code. But being heavily involved in the coding, billing, and compliance process, I have seen that, sometimes these little errors of really not knowing what's being put on that claim form can be done accidentally. Typing in, just transposing numbers, that's a problem. So make sure that you are accurate and take that time. Just take the time. Think of it as going to a shooting range. And everyone always thinks, because I've been to one of those before. Those are fun, by the way. It's in a controlled situation, so you want the controlled situation. But think of going to a shooting range, and you're pointing it at that paper person way in front of you, and you're trying to hit the bullseye in the middle. And basically, they just say, be really quick, and hit as many as you can. You want to have 20 shots, out in the last, next 25 seconds. And you just keep shooting, and you're all over the place. But what if you took some time? What if you actually took some time and you ended up only getting 10 shots out, but they were bullseye, they were accurate? You're going to save yourself so much more headache in the long run, if you try to look at accuracy over always speed. Now, I want speed, but I also want accuracy. The next one is services not covered and coverage terminated. And again, a lot of insurance information can change at any time. It's not just, January to December anymore. So it's crucial to verify treatment coverage every time the service is provided. And verify, you don't always have to call and everything, but just make sure that they still have that insurance. Make sure the services you're providing are covered and the patient's coverage hasn't been terminated. And then also there's tools you can use for that. Consider using medical tools and billing software from the payer to prevent errors on that. I know they have it with Medicare, and it's important that you use that before trying just to use the paper trail. Coding issues in healthcare. So this is, I feel sorry for a lot of coders out there, because they continue to use outdated code books, and then they try to go on social media to try and get the correct code. And so, you've sometimes some practices use coders to code and billers to input, and that's a problem. And then also I've noticed that sometimes the diagnoses and the CPT codes don't link or don't match together. And again, your claim will be denied. So you can't diagnose somebody, for example, with a cough and treat them for nausea, or diagnose them with an ankle fracture and then submit for an EKG. You have to make sure that you have consistency with that. So that's a really big issue right now. Bundling and unbundling medical procedures. So a medical coder can occasionally bundle several procedure codes or not know or check the MUEs, medically unlikely edits, or check the bundling guidelines or anything like that. So as a coder, it's your responsibility, whether you're certified or not, to look at which procedures will bundle, which will be inclusive. So for example, if the patient has an office visit and a minor surgery in the office on the same day, you may try to unbundle it with a 25 modifier. But let's really look at that. Was the reason that the patient came in for that minor procedure? Then there shouldn't be an office visit coded. So unless it was for a completely different reason that was not anticipated. So you schedule a patient to come in, let's say for a joint injection, that's what should be billed. But let's say the patient's coming in, they've got shoulder pain, the doctor has to work them up, and then they determine, let's see if a joint injection will work, then there's a possibility you now have a 25 modifier. But let's say you're an established patient and you're coming back in because you have frequent, body lesions, and you're in a dermatology office or primary care office. They're like, you know what, we need to remove some of these. They look like possibly the start of some basal cell. Come in 2 weeks and we're going to get that started. You come in 2 weeks, and the patient comes in, I should say, and they have a couple of removals. The doctor checks it. Prior to having that done, they also say, how are you doing? Okay, this is what we're going to do. There's no E&M there. And I see a lot of times evaluation and management services being coded for that. Also in surgery. If you're doing, let's say, a diagnostic arthroscopy, so a look-see with a scope to see, what's going on in the knee, and then you end up with an arthroscopic medial meniscectomy, you only bill the major procedure because the diagnostic part is inclusive. So you have to really pay attention to bundling edits. And then lack of follow-ups. So this is number 10. If a medical biller, doesn't know how to follow up on outstanding, payments that are due consistently, your cash flow is going to be affected. And I don't want to throw this just at the biller. It's collectors too. And you need to have the right software, follow-up reminders, some kind of systematic claims checking and reports that you can that you can keep referring back to keep track of financial status for the patient, payments being received. So back in the day, and I've been doing this since, oh my gosh, I'm going to age myself now, the early 80s, we used to have to print out on our printer that had, those side pieces of paper that you had to tear off. And we used to have to print out our accounts receivable and then go through each patient, look and see manually what was still owed if they were in a 30, 60, or 90 day or higher aging, and then find their insurance, again, manually pull their chart off the wall, and then try to find a way to call the insurance company and say, okay, what was billed, as we're looking at their paper claim in the chart. Nowadays, you have it so much easier with all the digital and electronic and just a way to track things from, a completely electronic perspective. And it's so much different than it was back in the day. And sometimes I feel like we were a little more efficient back in the day than some of the things I'm seeing now. I gave a webinar this morning, and I was talking about something that was brought to our attention from WPS and Novitas Medicare, and they were talking about third-party billing companies and what they're doing that's driving Medicare crazy. They're making calls to generate and drive up providers' costs by putting them out of compliance because, again, you're supposed to know what the tools are to be able to bill for services. They've got the IVR system, which is the interactive voice response system. Those are online tools to verify status of a claim or patient eligibility. And until you've used those, you're not supposed to call Medicare. And a lot of the third-party third-party billing companies, they're also using robocalls, and they're asking, questions like, why was this claim denied when the bill contains a modifier, let's say for an ABN, and they know they're going to get a denial or the practice did it on purpose, and then they're still calling to say, why was this denied? Or they're calling for mailing address questions. And so they can, what Medicare basically said is, by the way, you're responsible for your vendors being, doing this stuff, so you better have them stop it. So it was a definite problem. And we just don't want you to get caught up in some of these things. And hopefully just really try to eliminate some of these errors, revisit your processes. A lot of medical facilities don't have formal billing processes. And you can see where the leakage is, they call it now, instead of weak points. I can see redundancy in the processes. I actually think that medical practices, doctors' offices are a little bit better on this, on making sure that they have relevant and they operate relevant information, relevant workflows, and they operate a little bit more efficiently. But we have so many healthcare regulations, emerging, technologies. We have so many new illnesses, newly discovered treatments, and staying up to date with new billing codes and our new billing practices, new CPT codes, new ICD-10 codes. You're going to have some error. It's just going to happen. But you want to avoid duplication. You want to avoid redundancies and just continuing to kind of hit your head against the wall. So I just wanted to put it out there to really take a look at your processes. We're in the summertime now. Do a spring summer cleaning and say, you know what, we're going to sit down and figure out, how do we do this? How do we follow up on a claim? What's in our compliance manual? What's in our billing manual? How do we train our staff? And is it still the most efficient way to do things, or should we maybe revamp this and everyone needs to be on the same page? Okay, well, I appreciate everyone spending some time with me today. Personal tidbit is I get to go to my favorite restaurant this week for my friend's birthday. We call it Bourbon Steakhouse in Monarch Beach, California. It's quite a great place, but has ocean views and everything, so we're excited to go there. So if you ever get a chance to check it out, it's Bourbon Steakhouse OC. Look at those views, look at that menu. If you're ever in California, check it out. So everyone, really have a good rest of your month, good rest of your day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.